All right, good morning, everyone. My name is David Davis. I'm the Communications Coordinator with the Heart Disease and Stroke Prevention Program. I want to welcome you guys for showing up today. As a friendly reminder, please mute your microphone when you're not speaking. I will be monitoring the chat today. We do have a full plate on us, so we're going to try to hold the questions till the end. So if you want to type them into the chat, we can go back at the end and address them or hold them till the end. We're going to do our best to keep this to 1 hour. So if we have some questions we don't get to, please put them in the chat and I will get our speakers to address them, and then I will follow up in an email after our webinar. Right now, I would like to introduce our KHDSP Program Manager and Task Force Steering Committee member, Benita Bobo. Benita, the floor is yours.
Great. Good morning, everyone. Thank you for joining our third month of Task Talks. We are so excited about the presenters we have today. I could probably spend at the next hour talking about these two ladies, but that wouldn't make sure we get to the HTN part. So I want to make sure that we are cognizant of your time. So I'm just going to say that when you're successful in a program, 9 times out of 10, you have champions, committed champions. These two ladies are committed champions to this program. Very proud of the work they've done in the last few years. From where they started to where they're at now is just magnificent. And I couldn't say enough. Like I said, I could take the next hour. But instead, let me go ahead and read their bios for you so you'll have the background. First, I'll start with Kari Moore. Kari works in the Department of Neurology at the University of Louisville, assisting in the development, growth, and ongoing certification of the Comprehensive Stroke Program. She serves on the Department for Public Health, Heart Disease, and Stroke Prevention Task Force Steering Committee and chairs the Kentucky Stroke Quality Improvement Project, which focuses on statewide stroke systems of care. She participates in nationally recognized stroke clinical trials and independent investigator-initiated projects with her work presented at the International Stroke Conference and the American Academy of Neurology. Her clinical duties include serving as an acute stroke telemedicine provider, outpatient stroke and cerebral vascular disease clinics, and leading a multidisciplinary cardiovascular risk clinic focused on blood pressure self-management and lifestyle modification, which you'll hear more about. Our second presenter, and they'll be doing this together, is Kristin Munro-Leighton. She is the Director of Health Education at Family Health Centers, a network of community health centers in Louisville, Kentucky. She is responsible for developing and implementing programs to provide information, tools, and support to assist Family Health Center patients and community members in achieving their health goals. Health education programs cover healthy eating, physical activity, smoking cessation, management of chronic health conditions, healthy pregnancy, child development, child safety, utilizing evidence-based curriculum and practices, and conducting in partnerships with numerous local partners and with the support of multiple grants. Kristin graduated with her MPH from the University of North Carolina, Chapel Hill, and she lives in Louisville with her husband and 2 sons. Let's welcome Kristin and Kari, and we look forward to your presentation.
All right, thank you, Bonita. So this is Kari. David's going to pop up just a couple polling questions before we get started. If you'll take just a couple minutes, we only have 2 questions. It's not anything that's going to be too long.
Okay, of course, we seem to suddenly have an issue, Kari. My poll has disappeared, and it says I am logged into another device, and it won't let me do it. I'm gonna give me 1 more second to check something, but I think Houston may have a problem. I apologize. Benita, can you look at the bottom and see if you have it? I don't think we're going to find it.
So did you all get the poll? I just relaunched it. Okay.
Okay, so, there you go.
If you'll please take a moment to answer. Oh, it ended so quickly. Oh, no, it didn't. Okay, it's still going. All right. Sorry, we're new at this. This is the fun part of this technology system.
And does it say share? Because I am not seeing the poll.
I think it just popped up on everybody's.
It did. It popped up for us to answer.
Okay.
Okay, good. Thank you.
All right. So good. This gives us a good idea of some of the familiarity with a couple of the things we're going to be talking today. Okay. Now let's see if I end the polling, if it goes to the next question, which it may not do.
There should be a drop down menu.
And here comes the next one, I think. Everybody can see the second question. Are you currently a care collaborative coach?
Yep.
Yes.
Perfect. Okay, great. So we have some folks that are experienced with home blood pressure monitoring and involved in programs themselves. And then we have several folks that are also care collaborative coaches. So perfect. All right. Did the poll go away for everybody now?
Yeah.
Okay. All right. So let me get our talk put up here. All right. So for everybody, I know it's been a pretty inconsequential last 12 to 18 months. Not a whole lot's been going on and not a whole lot has changed. So it's been a difficult year in more ways than one, and not to make light of the situation, of course, but we've all faced different challenges depending upon our situation, either personally or professionally, with our jobs, continuing programs, et cetera, et cetera. So today we wanted to be able to speak with you about how we were able to sustain a team-based cardiovascular risk clinic with a focus on home blood pressure monitoring during the unexpected pandemic. And we will focus on team-based care as a key component of blood pressure monitoring and control, as well as the implementation, barriers, solutions, data, and then sustainability, and how you can adapt, or how we looked at adapting this team-based care model during an unexpected pandemic so that we could continue our program. So just some background, as most of you are in public health, these numbers are not new to you or surprising, but this is the most recent data released this year in January with the statistics that come out every year from AHA-ASA. And so we know that over 121 million Americans have high blood pressure, and it's at a cost of over $50 billion a year. And when we look at the breakdown between males and females and ethnicity, we can see here that we do have a significant issue with all men and women, as well as different nationalities. But of course, the African American or Black male remains at the highest risk or at the highest prevalence of diagnosis of high blood pressure. One of the things that I continue to find interesting when we come down to the bottom chart, though, is when we look at awareness over the last 20 years compared to treatment, compared to control, and then it's broken down again here in the different categories. And we see, if we just even look at overall from the late 1990s to early 2000s, about 50% of folks were aware that they had high blood pressure. By 2015 to 18, it's up to 61%. So it's getting better. I guess I would have thought, with all of the campaigns, that number would even be higher, that you would be aware. And then you can see how it breaks down here by category. And when we look at treatment, 37% of folks were treated early on, and that's up to 50%. So 50% of hypertensives are now being treated, which is still really, I think, concerning in this day and age. But when we look at control, so 12% were controlled up to 21%. But if you look at the two categories here in every bracket, what happens is it's stagnant, or it's even less than it was before. So if you say, okay, well, we had 24% of people controlled in 2007 to 2010, that's declining. So the more modern our medicine is becoming, the more modernized programs we have, the more flexible programs we have, we still have a lot of work to do. And we think about other cardiovascular risk factors also in this same report, looking at the most common risk factors, whether or not they are, as far as prevalence, ideally controlled, intermediately controlled, or poorly controlled. The biggest gain we've had is in smoking. When you look at, we're over 60% of, improvement there. But when you drop down, look how concerning this is with body mass index, physical activity, and healthy diet. It is just devastatingly poor overall, which is then we're seeing improvements in total cholesterol, blood pressure, and diabetes. But these three factors right here are going to continue to drive the blood pressure and the diabetes, and we're not even over 50% in the ideal range. So we do continue to have a significant problem, which I know all of you are completely aware of. So what about Kentucky? Well, we're divided into these different regions, aren't we? And what's the rate of high blood pressure by region here and here? And the thing I really just wanted to point out is we know, right, about 40% of Kentuckians related to the most recent BRFS data that we have in 2019 have hypertension, broken down here again by males versus females and whites versus blacks. As we age, the rate of high blood pressure goes up. And then two very important factors. The less educated we are, the lower income bracket we're in, the higher the rates of high blood pressure. So we know social determinants of health are impacting some of this. When we go to the CDC Interactive Atlas and try to run and break down by county, here you see in your upper left-hand corner, the hypertension-related deaths for all Kentuckians over age 35. We know we have a problem in Appalachia and Eastern Kentucky, and look at the non-adherence of blood pressure medication in Appalachia, right? When you come down and you look at housing problems and high blood pressure and how that's influenced these darker areas. And then when you focus in on, well, where do our African American or Black population primarily live? These darker counties. And of course, the Louisville metro area is a high incidence of, or a high rate of Blacks or African Americans. Also, our risk factors, looking at cardiovascular risk factors related to BRFS, is really equal to the US, but we far exceed those categories in tobacco use and high blood pressure. We're close on some of the others. We're either right there or higher, but we have a significant, I think, discrepancy here when you talk about percentage rise with tobacco use and with high blood pressure. So what about our Louisville metro area? Just setting the stage for why are we having this clinic with the family health centers in the Louisville area? Well, this is where you see the heavily populated heart disease adjusted death rate per 100,000. It's darker in the West End. Same here, our Black and African American population compared to the rest of our county and the Louisville metro area is primarily focused in the West End. Our economic struggles are heavily troubling in West Louisville. And with the last report that we have coming out of the Louisville metro area and the health department, it stops at 2015, but concerning is this spike and upward tick in the mortality rates for heart disease and for stroke. And this particular light blue line here, of course, is our African American or Black citizens. But again, in all categories in heart disease, we were on the uptick. So the good news is we know that blood pressure reduction can decrease cardiovascular mortality as well as even decreasing risk. So as Bonita said, I'm a stroke specialist. I provide care for stroke patients. So not that I don't have an interest in cardiovascular or the heart, because they're both directly connected. But when I'm looking at my data, I'm thinking of stroke patients and what I want to be able to give them knowledge with. So, as part of the care collaborative chaining, this study is cited frequently. Looking at reducing systolic blood pressure by little increments has a significant impact on the mortality of stroke as well as cardiovascular disease individually, and then the total mortality reduction. All right. So little changes can make big differences. And we know with the study published in Lancet that if we can decrease the systolic blood pressure by 20 millimeters of mercury or the diastolic by 10 millimeters of mercury, then that's associated with a twofold decrease in stroke mortality. Okay. But what about, well, we want to prevent them from ever even having a stroke, don't we? I mean, I don't want somebody to have a stroke and live disabled. I would like to prevent them from having a stroke in the first place or a heart attack or significant cardiovascular disease. and broken down here in the Journal of Stroke in 2017 by age. If we can decrease that systolic blood pressure by 10 millimeters of mercury, we can decrease the risk of stroke at all for those less than 60 by over 50%, which is where we really are focusing a lot of our efforts, right? We need to attract and start early so that we're impacting blood pressure control at a younger age. And again, as we get older, blood pressure incidence rises, so we would then continue. But the risk reduction is significant by driving the blood pressure down. And it doesn't matter if it's systolic or diastolic in the bottom chart here on the right. If you decrease it by 5 millimeters, 7.5, or 10 millimeters, you're again reducing the risk of a stroke by upwards of over 50%. So how does self-measured blood pressure monitoring come into play, right? Well, what is that? As most of you know, several of you are involved in programs. This is the opportunity to monitor your blood pressure outside of a clinical setting, an alternative to an in-office care. So more in the patient's routine, what they're doing in their normal everyday activities and lifestyle. And if they can write it down and record it, then we have a better idea than just that one snapshot of time of what's happening with the blood pressure at that provider's office where they are, which may not always be an accurate blood pressure reading. And self-measured blood pressure monitoring is endorsed by several professional organizations as well as public health agencies, which allows us to have that support of using it. Now, there was a bit of, I would say, slow on the uptick of providers to maybe pick this up and rely on it. There's a lot of concern about, is the equipment accurate? Are patients using their blood pressure cuff appropriately? Which is where, the coaching and the educational encounters come into play. So what's a healthcare team? Well, the Institute of Medicine, now known as the National Academy of Medicine, defines a healthcare team as 2 or more health professionals who work collaboratively with patients and their caregivers to accomplish a shared goal. And importantly, it strives to meet the patient's needs in the environment they're in and make them full participants in their own care. Healthcare teams are evidence-based. They're associated with better performance measures and healthcare quality. And really the drive to incorporate healthcare teams began to be more talked about, I think, was when we changed from a fee-for-service reimbursement process to more of a value-based payment model and structure of care. Now, it is well documented in the literature that team-based care can be more expensive. However, at the end of the day, when all the cost analysis are run, it is still more cost-effective than the disease burden itself. And team-based care is supported by the AHRQ. So what do you need to have as far as characteristics of a team in order for your team to be high functioning and succeed? Well, you have to have a shared identity, values, and goals. There needs to be good leadership within the team and coordination. Requires regular meetings and adequate staffing, as well as open communication and dialogue about what's working well and what's not working well. Really important, I think, is when there's disagreements that you have good, constructive conflict resolution. And then you help one another, right? You're there for each other and you support each other because things don't always go perfectly. And you have a lot of unexpected, I don't even know what to call it, unexpected things happen to you when you're involved in a team with patients from different backgrounds. And so how do you share tasks? How do you shift within that meeting or with that encounter with the patient or the participant to make their experience successful? And I think as we go through some of this, you're going to see how the characteristics of this team really lead to success or failure of a program. So what about the format? How can team-based care be given? Well, it can be one-on-one counseling. Doesn't have to be in a shared multidisciplinary group like we are right now. It can be web-based. It can be telephonic. It can be through a classroom type setting. It can even be through texting or secure messaging or other technology. But what's important is this feedback loop that you see here. So it's a constant dynamic process between the patient and the providers, and whatever the content is that you're imparting or working with them on or navigating their care with, which in our case, of course, is self-measured blood pressure. So having them take their blood pressure, record those readings, talking to them about appropriate lifestyle intervention, having good short-term goal setting with them and including them as active participants in that shared goal setting model, as well as identifying potential opportunities for community support and looking at where they live and how you can meet them where they are by providing interventions that will best help them. And small interventions, not large interventions or multiple interventions at once, which we'll be able to highlight. So most of you were familiar with the CARE Collaborative, which is the Cardiovascular Assessment, Risk Reduction, and Education Collaborative through the Heart Disease and Stroke Prevention Program, which is really Kentucky's Know Your Numbers campaign. It's funded through the CDC's 1815 grant that's awarded to the HDSP. And it's an educational encounter and a tool that we use to educate participants on the signs and symptoms of stroke and heart attack, what the vascular risk factors are for heart disease and stroke, and looking at how we can work on opportunities for smoking cessation, control of the blood cholesterol, blood pressure, sodium reduction, weight control with BMI, and then also looking at the A1C. So if you'll remember, the CDC's like know your ABCs, and A was aspirin. So in Kentucky, we chose to change that to A1C so that we could focus on diabetes and good A1C control. So this is a snapshot of the CARE Collaborative card using the stoplight approach from normal blood pressure less than 120/80, which of course is optimal for most people in the general population, focuses on the signs and symptoms of stroke and heart attack over here, has a place for them to document their risk factors, any surgeries or self-management goals, and then they don't have to fill all of this out, but they can, their pharmacy, emergency contact, etc., and then the name of their medications, the dose, and what they're taking. And then over here you see the Know Your Numbers piece about what ideal values are in primary prevention. This is a pocket-sized card, can fit easily in a pocket, a wallet, a purse, etc. So enter our collaborative partnership, okay? And so the University of Louisville School of Medicine, Department of Neurology with the stroke program, which is who I represent, working with the Family Health Centers of Louisville, which Kristin represents, is a health educator there. And then Sullivan University is not directly contracted as part of the funding or the grant itself, but they're an integral piece to this because the College of Pharmacy at Sullivan staffs the Family Health Center clinics. So their faculty are the pharmacists on site at the Family Health Centers dispensing medications. It's also a clinical site for the pharmacy residents and pharmacy students. So we have a great opportunity to also teach pharmacists and future pharmacists about a multidisciplinary team, working with patients with shared goals with varied healthcare providers. And then, I don't know if it's fortunate or not fortunate for them, but they've also learned how to do telehealth in a multidisciplinary team during a pandemic. And they've been troopers and they have succeeded. So we are one of the programs that's part of the heart disease and stroke prevention programs outreach to implement this CARE Collaborative to impact the numbers of Kentuckians and reduce high blood pressure in our state. So the University of Louisville for some time now has been focused on improving life for those in West Louisville. And the Signature Partnership was launched. And we actually started this program, nothing like it is today, with the School of Nursing at the Catholic Enrichment Center down on Broadway with 7 people in a small classroom with nursing students. So the evolution of what we've been able to do to grow the program has taken time since 2012 or 13, but our goal is to be able to enhance the quality of life and economic opportunity for our residents in West Louisville and do the best that we can to try to eliminate and reduce disparities for those citizens as it comes to education, health, economic, and social conditions. And in the 10-year report that they put out in 2017, the university had garnered over $30 million in grants and contracts with efforts to help revitalize that effort. Now, the University of Louisville is not the only healthcare system or only business, private or state funded, that is working hard to reduce disparities. This is just one initiative coming out of the university to try to improve life in that area that we know is one of the most disparate in urban Louisville. At this point, I'm going to turn it over to Kristin to talk to you more about the family health centers and some of their missions and goals.
All right, thank you, Kari. As Kari said, Family Health Center joined with the KDSP's efforts and the U of L Signature Project outreach about 5 years ago. Family Health Center, if you're from Louisville, you're probably familiar. We have 8 locations in medically underserved areas of Louisville. We are a federally qualified health center. So we serve areas where medical services are traditionally not available, and in which the population is disproportionately affected by cardiovascular related deaths and risk factors, as Kari discussed. So Family Health Center's role has been to help connect these programs to the community members and to our patients. We have about 40,000 patients at our 8 locations, and we see we have more than 130,000 visits a year. Like those of you who are also at FQHCs, we operate with a sliding fee scale, which is based on income and family size, and we're really open to anyone who needs healthcare, whether or not they're insured, whether or not they are a legal resident. You know, really any person can come to Family Health Center and receive the primary healthcare that they need. Like most FQHCs, we provide medical care, primary care for adults, women, prenatal care, pediatrics, but we also have a lot of supplemental services to help patients overcome social determinants of health. And these include health education programs, which I run, and then clinical pharmacy programs, which has been part of this project. You can see, this is our 2018 data, but you can see that on the list of common diagnoses for Family Health Centers patients, hypertension is the most prevalent. In the next year, hypertension actually jumped about 700 more patients. We really have about 25 to 30% of our adult patients who have hypertension. The majority of those are not controlled. We have about 3,500 patients with uncontrolled hypertension. And those are the patients, the patients who need the most help in that group are the ones that we're trying to reach with the program we're telling you about. So these are the current members of our multidisciplinary team, and some of them are on the call today, so shout out to them. Like Kari said, it started in one format, and it's had quite an evolution over the last 5 to 7 years, but this is the current team. So Cassie, the Sullivan clinical pharmacist, it operates out of as a service of her program. Kari provides clinical and cardiovascular expertise. Judy and Lindsay, who are on the call, and I do patient education. We have a community health worker, Priscilla Ewing. Nana coordinates our patient visits, and Dr. Liu does our data analysis. And we wanted to share a little bit about that evolution of the program over the last few years, because team-based care, as Kari was explaining, can be very effective in helping patients with blood pressure, but it's not something that you just start right away and you have the perfect team and the perfect model. I think it really takes some evolution to get the right people and to figure out the most effective ways for them to work together. And so we've had a variety of systems and methods that we tried until we got to where we are now. So we are in year 5? 5. 5, okay, sorry. Last 6, I've lost track. So in year 1 and year 2, our format was really a class-based format out of the health education program. So patients were able to enroll in the fall. The plan was that they would participate through the fall, winter, and spring, attending monthly classes. They would receive a blood pressure cuff to do self-monitoring, and we would do some individual help with patients at that monthly class, and then some group education on the monthly topic. So that was our format for the first 2 years. It had some pros and cons, and we enrolled about 40 patients each year in that format. For year 3, we had a two-pronged approach. So for year 3, we tried to implement care collaborative for all patients at family health centers, something that the medical assistants would use to do some brief education with patients while they were taking their blood pressure and record that in our electronic health record. And then we continued the more intensive program that, if someone's blood pressure was uncontrolled at that blood pressure check, and as part of the care collaborative, they agreed to be referred to the program, then they could get some additional help. You want to switch the slide, Kari? So you'll see for year 3, the program was similar, very similar in the educational topics. Patients got the cuff. We used the care collaborative. The biggest changes were that instead of enrolling at one point in time and then continuing throughout an entire year, we changed to meeting with patients one-on-one for the entire program and having rolling enrollment. The other change was that we pulled in the clinical pharmacy program more. So in the first couple years, they had been kind of a guest speaker when we were talking about medication adherence, and their students had volunteered and helped us in some ways. But now they were really becoming more of a core component of the program and providing the services.
Hey, Kristin, could I jump in for just a second?
Sure.
I do believe you have somewhat of a lapel mic on. It's on the cord of your headphones. Is that where your mic is?
No, I might have accidentally turned it on.
Oh, but no, I think that's what's working. Every time you bump that, it's pretty staticky. So kind of be cognizant of it being there. Okay. Sorry, continue. Thank you.
All right. So that was our first 3 years, and Kari can share some data about how the impact of the program during those years.
Yes, so we did collect data year 1 and year 2, but the numbers were small, right? So it was more about how do we get a process down and not as much about the data. So with the 40 patients, it wasn't enough. As Kristin said, they have over 3,000 patients there to try to figure out how are we going to continue. We needed to have more data. So year 3, with 120 patients, you can see that within the first visit, the average blood pressure was 138.9 and decreased at their last visit down to 134 with a change of almost 5 millimeters of mercury. And the diastolic same decreased to 2 millimeters of mercury. And of all of the patient population, 40% of the patients dropped their systolic blood pressure by 5 millimeters of mercury, and 32% dropped by 10. So pretty significant drops. But when we look at the patients who came to the program with uncontrolled high blood pressure based on JNC7, right? The blood pressure is greater than 140/90, and they attended at least 2 or more visits, which was a little over a third of the patients. Their blood pressure average started at around 150, but decreased by 13 millimeters of mercury on average, and the diastolic down by almost 5. Okay, so in those that really needed the most significant change to bring them into control, we were able to see that in quite a few patients. 76% of them dropped by 5 millimeters of mercury, 61 by 10, and almost half dropped by that 15 millimeters of mercury. So some significant, we felt like really some good significant changes in blood pressure control to allow us to begin to draw some conclusions about things that were working and were not working. And as a result, one of the things, the opportunities that Bonita gave us was there was a workshop being held by the NIH in 2017 and under the National Heart, Lung, and Blood Institute. And this was a workshop looking at what's working and what's not working as we're trying to reduce cardiovascular disparities in community-engaged implementation research. And I'm gonna tell you, I was in the deep end of the pool at this conference. I just have to say, I was the one floating with my swimmies on, because you have the head of the Heart Disease and Stroke Prevention Program from the CDC. You have the head of the NHLBI Heart Disease and Stroke Prevention, and then Dr. Mensah, of course. And then all of these folks here are esteemed public health researchers throughout our country. And Dr. Schoenberg is in public health at the University of Kentucky, and then I was there to sort of represent the clinical side. So what did we come out of all of that? Well, it was a great learning opportunity about interventions that can work and those that have been hard to sustain. Because the thing is, as you all know, a lot of times the grant funding is there, but when the grant funding dries up, so does the program. So how do you continue a program that is helping a disparate population with, that is sustainable if your funding dries up? So those were some of the things and conversations that were being held, and the paper was published in 2018 about opportunities for us to, really focus in on how would we do that. So a shift to our clinic model really in year 4, in July of 18, and year 5, where we now have this dynamic process with an official clinic that is run out of the pharmacy and overseen by Dr. Hobbs, the pharmacist at Sullivan University. It went through P&T, which is Pharmacy and Therapeutics, and the Med Exec Committee, which is, if you're in a hospital institution or a clinic-based site like that, there have to be protocols that are evidence-based and well-driven, and it allows us the opportunity to make blood pressure dose changes of some of those medications, as well as check labs that are appropriate based on a protocol that the providers at the Family Health Center have already agreed to. So we start our clinic days long before what happens right in this wheel right here with pre-rounding, et cetera, which Kristin is going to talk about when we look at the workflow. But we have Judy, who performs the care collaborative and makes sure that the patient knows how to use their blood pressure cuff. They understand how to document and identify which zone their blood pressure is in, which of course is really important, right? Because we want them to know, is it getting better? Is it staying the same? And if it's out of control, when should you be concerned and talking with your healthcare provider? And what high blood pressure is. Then we have Nana, and sometimes their roles, Nana will go first and then Judy will come, and sometimes it's back and forth or it's done at the same time. But Nana is one of our PhD candidates in social work at the University of Louisville. She's also a Fulbright scholar, and her job is to do all of the intake and coordinating and scheduling of the patients. But on the day of their appointment, she utilizes the Prepare tool to screen them as far as all of their social determinants of health. And then you see here Priscilla, who is just a rock star, community health worker, who sometimes she enters the picture right here. Nana identifies an opportunity where the patient needs more resources or structure to navigate the healthcare system, and she can make that referral directly to the community health worker designated for our program. Or sometimes Priscilla's over here, and we all as a team decide that we need to make a referral to the community health worker. And sometimes Priscilla comes to the appointment or picks up the patient for the appointment and brings her the patient. And she's at the very beginning with Judy, helping the patient navigate with some health literacy concerns or other areas where they need navigation in the community. And then we move into the pharmacist, either the pharmacy resident or Cassie herself will go into the past medical history as far as identifying vascular risk factors, looking at the medications that the patient is currently on and reconciling those, trying to identify any potential side effects of those medications. Then we move into the clinical side of things, focusing on, are there any, we do the PHQ-2 and 9 to assess for depression. And we look at the review of systems. So in medicine, we look at all of the systems of the body to determine if people are having symptoms, the same questions the doctors will ask you, like a checklist. Are you having any of these problems or any other concerns about your health? And then after all of that, discussion, thorough, make sure the patient understands the program, make sure that they aren't having any emergent needs. Then we work on setting short-term goals with them. And usually the first goal of the program is make sure you're comfortable with your blood pressure cuff and checking your blood pressure and recording your blood pressure. Some are very high performers and they want to jump right in and set a short-term goal with Kristin and Lindsay after they've had discussion, whether it be around smoking cessation or physical activity or diet changes. And some of them have even made some of these small changes prior to coming to the clinic. So we are a reinforcement for them and offer opportunities in the community, classes, as Kristin was saying. The Family Health Center has just a plethora of opportunities to learn about chronic disease management, to learn about healthy cooking, blood pressure, as far as physical activity classes. They have yoga, they have Zumba, all of these things that they have had to adapt over the last year, but still, and more opportunities for the patient to work on some of these factors that help reduce cardiovascular disease and bring down blood pressure through lifestyle change. Then we set a follow-up appointment and we send a note to their primary care provider, and we have the opportunity to immediately task that patient's primary care provider if there's any immediate concerns. So what happened in year 5? Year 4, we don't have good data because it's apples and oranges, because we were working with, this is now an official clinic, we were entering data into the EHR, and then when it would be exported, sometimes it would come out what we needed, sometimes it wouldn't. So we were having to go back to the EHR and make some changes there with the IT department, along with the folks who are doing the data analysis. So we used year 4 to really work through data entry and data export and being able to turn it into something meaningful. And what we ended up with last year's data is we had 284 total encounters with almost 100 participants. 64 of those were new and 74 returning patients coming from multiple visits. The median age was 58. Here you see the breakdown by gender, predominantly Black or African American population. And then, poverty level for our patients is high. Okay, so these are folks who have a lot of disparities and need help with housing, paying their utilities, et cetera, et cetera. And over here, our age, most of our patients are between the ages of 45 and 65. And here, what we really wanted to be able to track is how's their overall cardiovascular health. So now we know what's the breakdown based on other risk factors that we're also dealing with. And about a third have diabetes, 60% have high cholesterol, almost 50% are obese, and over a third are smokers. And what we were able to see is that we were able to change the diastolic blood pressure by almost 4 millimeters of mercury and the systolic by almost 8 for those patients during that year period. And when we look at how we're shifting the zones, right, we're making an impact for those that came to the first visit in the red zone, which was almost half. By the last visit, that was down to 24% of patients. Those in yellow were up to 58%, and our number in the green had gone from 7 to 17%. So numbers that we wanted to see. We're feeling really good about our program. We're thinking, yes, we have this down pat. We're ready to move into the next phase, which is expanding sites, which is working with Bonita to figure out how we're going to take this through Kentucky, through telehealth and ad providers. And sorry, I have one other thing to tell you because I think this is important, especially to public health, and I forgot it was here. So there were 139 referrals made for additional services. So these health education type classes with over 217 lifestyle changes made, which averaged at 2 per patient, and 84% of patients were adherent to their medication, which is key, right? That's also a key piece to this. And of the 98 patients, we were able to graduate a third of them. About a fourth of them continued on. And then here's where we were struggling. We're losing people, right? But as I started to say in my big buildup, things are working. We're trying to focus in on how are we going to have retention at this point, right? This is one of our big gaps is retention, and we need to work on this, and we know it. And then as Kristin says, we ended up with a dumpster fire. So I'm going to turn this over to her because the dumpster fire landed right in her plate because she's at the facility that houses this program, and all of the coordination and moving parts through the leadership and administrative process really run through the Family Health Center.
So like all of you, about a year ago, we know our exact date. I know the exact date I last saw Kari in person. We've of course, like you, found every aspect of our lives and our work, and this program affected. And for a time, we did come to a screeching halt, but we really felt that we needed to find a way to continue. And Kari's going to talk about a couple reasons why.
Yeah, so early on when this came out, right, you know, I mean, we're all, if you can think back to that time, it was, well, what does this mean? Can we go on, you know, seeing people? Can we, you know, how much contact can we have, right? Because it was stay 6 feet away, wear your mask. Then it was, you can be in groups, but not groups more than 10 people, right? Or then it was 50, and it would fluctuate. But what we did learn early on with the early science that was coming out was that hospitalizations were 6 times higher and deaths were 12 times higher with COVID-19 patients that had underlying cardiovascular disease or diabetes, right? So that's hitting our program at home. Just number one, you saw the risk factors and what our patients had of those 100 people. And we know that if you had high blood pressure or diabetes or coronary heart disease, that it increased the risk of infection and severity of lung injury. All right, and over here is just another way of looking at it. Obesity was a key factor, as well as the chronic lung disease. Over here is just another way to look at it. If you're a statistics type person, you know, 2.6 more likely times to have a mortality if you had COPD or diabetes or hypertension over here. And if you had more than one comorbidity, why then your increase of death went up higher. And then what did we learn? Well, we learned that, you know, our minority population is at an even higher risk. So non-Hispanic American Indians, non-Hispanic Blacks, and Hispanics and Latinos, right, are at a higher risk of mortality. So we said, oh my gosh, what can we do? This is our patient population at the family health centers. You know, we have refugees, we have a high Hispanic population, we have a high African American or Black population. What do we do? And really, as Bonita said, you know, Kristin and Bonita and I have been working together for a long time. And I think all of us felt this sense of responsibility, number one, to the community. I think number two, we felt a really big sense of responsibility to the heart disease and stroke prevention program, because, you know, they're funded by the CDC. So what happens if the dollars go to waste and they're not used? Then what happens? Where does the money go? Does the CDC take it back? I mean, all of this was like in my mind in turmoil, you know, sort of being responsible for the overarching part of the program. So we decided collectively as a group, every member that you saw up there with their picture decided that we were going to figure out a way to continue this program. So this is real life right here. And I'll let Kristin take it over.
I'll just say I ran out of duct tape months ago and was not able to resupply. So you may see and hear people darting around behind me. So yes, we were determined to continue, but of course, like many of you have experienced, there are a lot of barriers to programming right now. And the benefits of the team-based model, you know, we see those in our outcomes, but it actually made it more complicated. It introduced some new barriers to have a team-based program and try to keep it going during COVID. But I think a lot of, you know, the time that we've spent working together, the team that we have, made it possible for us to get around some of those. So really the program would not work as we had been doing it. It was very complicated, as Kari was saying. We have multiple organizations involved who were all creating different guidelines. We had like a little 8x8 square office that, you know, there were 8 of us packed into sometimes, and, you know, constantly going in and out and constantly going down the hall to different exam rooms where the patients were, and then coming back and then going back in, and then, well, you go talk to them, well, I'm going to go talk to them. So that model just would not work with PPE and trying to be safe. So if we had to do it differently, we had to work through a lot of issues. So, you know, some of us are fortunate enough to be able to work from home, but we have 6 kids between all the staff members. Some of them are young, some of whom we're also trying to get them through school. There's a lot of technology challenges. If you're going to work from home, you may need technology you didn't have before, and access to EHR at home. One large challenge that we found for a team-based program is having a HIPAA-compliant telehealth platform that allowed multiple providers or multiple clinicians and educators with one patient, because most telehealth platforms are built for one provider to see one patient. But we have a team of providers who want to see the patient, and we have people from different organizations who have different levels of access into our EHR. So that was actually one of the trickiest things, and continues to be the trickiest issues to work around. If we're going to go virtual, we can't use a regular telehealth program. Scheduling has been very challenging because, with patients with a lot of barriers, you have a high no-show rate. And so, we, would always overbook before, but you can't overbook if you're seeing people virtually and, leave someone just waiting and using up their data plan for 30 minutes while they wait their turn. We had to work through, how were team members, what was their role going to look like, and how were they going to participate in this new format where the patient is virtual and we each need our turn with them. And we also had to rethink our patient intake process because, of course, we're trying to give the patient a blood pressure cuff. So how do we get that to them if the visit is virtual? How do we get them to sign their paperwork? So we had to think through a lot of barriers, like I said, some of which were specific to being a team-based program. The patients, of course, also had a lot of barriers to doing the program virtually. So a lot of people do not have internet at home. A lot of people don't have smartphones, don't have a tablet. If they do, their ability to use it, and especially to connect to a program that may require downloading an app, can be limited. A lot of our patients have had COVID-19, we'll talk to them. We spoke to them 2 weeks ago, and then we have a follow-up. And in that last 2 weeks, their parents and their brother both got COVID-19. We've had patients with family members die of COVID-19. So there's a lot of exposure to COVID-19 in our patient population. There's a huge impact of just basic needs being at risk, for housing, to food, to health insurance, because of the pandemic. So patients experiencing a lot of barriers, and then some of the services that they need access to was restricted at different times throughout the year due to COVID-19. Access to healthcare, access to community resources, like programs at Family Health Center, like the YMCA, like gyms. So barriers for us, barriers for patients. So over the course of weeks and months, we worked through a lot of these challenges. We are still constantly making adaptations as the situation with COVID changes, gets worse, gets better, as recommendations change, as guidelines change. And actually, I think something we didn't expect was that some of the changes that we've made over the last year that we had to make, I think actually put us in a better position. There are things that we will continue once we can go back to normal, and they put us in a better position to expand in ways that we wouldn't have been able to before. But, like everyone, we have had to find ways to manage the exposure to COVID-19 among ourselves and in our interactions with patients. We've found ways to have some staff on site, some at home, and all being able to participate in the virtual program. Within the course of just a couple weeks, we had to purchase and learn a telehealth platform. This is still, like I said, our biggest challenge. There's not a ton of options for team-based healthcare. And, our organization is pretty strict about HIPAA compliance. So we have had to manage basically two scheduling systems, because we have to schedule people in the telehealth system that we were able to find and in the regular scheduling system with our EHR. And we have to test. We had a lot of times in which the patient signed up, but then we found out at the time of their appointment that they could not get the technology to work. So now we have to test that in advance, which is another, just another kind of part of the process that takes time to get the patient connected. Further solutions, we had multiple workflows for different types of patients in person. Now we are probably up to double-digit workflows, and we've adapted them over the year. We've had to, we made an appointment flow for a hybrid appointment in which the patient is on site and some staff are on site, but some staff are at home. Then we had to suspend the hybrid appointments when the COVID numbers got too high. Now we're back to hybrid appointments. So we've had to create a lot of new workflows. Then one thing that we figured out was if we're not all in the same place and we can't be in our 8x8 office and figure out our plan and kind of create a strategy for the patient or just update each other about the patient without the patient being there, because when we're virtual, the patient is still in the virtual room with us. We have kind of these epic text threads during the clinic, not sharing patient information, but just like, hey, I need the link. Hey, someone else is on, who's going to join them? So that's really our workaround for, how we have a team, but all through this technology. We've gotten pretty good at doing warm handoffs within the virtual appointment. As Kari said, instead of having the pharmacy students work up patients that day and go into the visit, they do all of their rounding the day before and present the patient to us so we can ask questions and all share updates, because sometimes Lindsay and I have updates on the patient that may not be in the record from our work with them. And then we just had to come up with solutions for mailing blood pressure cuffs to people, having people pick things up at the clinic, and working around those barriers. And so Kari can share, despite everything, our initial results from the last year are showing that the program is still working.
Yeah. So basically just to show, I think we can just look at this and tell that with our 72 encounters and 41 patients and only 1/4 of data last quarter of last year, we're still seeing success and we're moving in the right direction, and we're pleased with where the numbers are going despite all the challenges. So moving forward, this current fiscal year, we want to continue to manage this changing landscape. We're desperately trying to identify telehealth vendors that meet the approval of the IT Department for Family Health Center. We're looking at implementing text and automated education messaging, looking at FHCs have a new HRSA grant. So how are we going to run these two programs simultaneously and coordinate the care? Preparing for a new electronic health record that will come next year, and then looking at how can we sustain our current data collection system with a new EHR. In year 7, we're going to enhance this telehealth platform, adapt to the new EHR, and continue or consider a remote blood pressure monitoring pilot that communicates with the EHR and will upload blood pressures, look at a self-management blood pressure toolkit curriculum, and then start a separate hypertension clinic for the Spanish-speaking population at FHC. And then, of course, longer term, we want to be able to expand this across sites, secure additional funding, and identify opportunities to include other non-English speaking patients. So with that, I'm going to stop. We're 1 minute on timeline, and I know we ran long, but I thank you for your attention. And I'll stop sharing this, David, so you can.
Excellent. Thank you, Kari and Kristin. Fantastic. So does anybody have questions out there? I do have one in the chat from Kirkland. It goes way back to the beginning of your presentation, so hopefully you can kind of think back. But he asked, do you think that the smoking numbers are down due to smoking cessation being a core measure with, is it JACHO, J-A-C-H-O? That's an acronym I'm unfamiliar with, and I'll let you address that.
That's a good question. On the inpatient side of things, I certainly think it hasn't hurt. I think it helps a lot. I think providers are focused on it during the inpatient side of things. Kristin, in the outpatient world, they handle a lot of these classes. So what do you think as far as the outpatient world?
It's as an FQHC for our quality measures, we do have to screen every patient for smoking and address it. So I'm sure that has had a role, and coverage for NRT and things that have happened in the last few years have helped too.
Yeah, I would agree. I just don't think we have a good way to measure it, but definitely I think all the emphasis in multiple arenas has helped with that.
Excellent. Any other questions out there, folks? Benita, do you have any final words you would like to say? I do have a couple announcements about our next task talks, but I want to hand it over to Benita. Do you have anything?
No, just to say thank you. We really appreciate you sharing all your hard work with everyone, and the challenges that you've overcome have just been it's quite impressive. Thank you both.
Definitely. Thank you. Thank you so much for doing this. I am going to share. Except I've lost it. There it is. Our next task talks will be March 25th. That is back to a Thursday at 11 o'clock. We do have someone from they're from the CDC, but they specifically worked on the new dietary guidelines for Americans that just came out. So I hope you'll join us for that. You'll see registration for that in probably about a week before I'll have that out. I will send out a link to the recording. All of our recordings end up on our task force webpage, so you can view those anytime that you want. I will be sending out a follow-up evaluation next week. Please fill that out. Be as specific as you like. Let me know any thoughts about this presentation, past presentations, any speakers or ideas for future presentations. We'd love to hear them. Other than that, I say thank you. We are just a couple of minutes over time, but I appreciate that you joined us. Thank you again to Kari and Kristin for putting this on. It was excellent. And we will see you guys next month. Thank you so much.